Hello, and welcome to the Cottage Center for Orthopedics Meet the Doctor, featuring Dr. James Bailey, an orthopedic surgeon affiliated with Cottage Health. I'm Christina Cortez, the Public Relations Manager for Cottage Health. I wanted to thank you all for being here today. Before we get started, I'd like to review a couple of housekeeping items to optimize your experience in this webinar. At the conclusion of this presentation, we'll host a brief question and answer session. So please use the Q&A button at the bottom of your screen to ask a question. This presentation is being recorded and you will receive an email within the next week with a link to view the presentation and PowerPoint slides. And now it's my pleasure to introduce Dr. James Bailey. Dr. Bailey is a graduate of the United States Naval Academy and served 6 years as a U.S. Marine Corps officer. He then transferred to the U.S. Navy and attended the Uniformed Services University of Health Sciences Medical School in Bethesda, Maryland, and completed his orthopedic surgery residency at the Naval Medical Center, San Diego, where he was recognized as Intern of the Year and Top Resident. Dr. Bailey then completed an orthopedic sports medicine and shoulder fellowship at Duke University, where he was an assistant team physician for multiple sports, including the Duke men's basketball and football teams. Dr. Bailey returned to the Naval Medical Center as faculty, specializing in sports medicine and shoulder surgery, holding multiple leadership positions, including Chief of Orthopedic Sports and Shoulder Surgery and Director of the Main Operating Room. In military medicine, he is considered one of the go-to surgeons for complicated knee and shoulder injuries across the Western United States and Pacific Rim. Dr. Bailey served as team physician for SEAL Teams 1, 3, 5, and 7 during his last few years in the Navy. In 2023, Dr. Bailey retired from the military after 25 years of service as a highly decorated military leader, surgeon, and educator, and joined the world-class team at Rue Hurwitz Orthopedic Clinic. He is a nationally recognized thought leader and educator in the field of complex orthopedic shoulder and knee surgery. Dr. Bailey is married to Mary Kate, also a Naval Academy graduate and prior U.S. Marine officer, and they have 5 amazing children. So now please join me in welcoming Dr. Bailey.
Well, thank you so much, Christina, Leslie, and the whole Cottage team for that introduction. I really appreciate it. Thank you for setting this up and giving me an opportunity to talk to the community a little bit. For everybody out there, I really appreciate you attending. I hope that this is beneficial, and I'll try and make my introduction or my presentation relatively brief to give you plenty of time to ask questions. All right, so very briefly in this talk, we'll talk a little bit about my path that brought me here. We'll give a little snapshot of some highlights of my prior military career that I left behind. We'll go through some top 10 things I know and maybe you should know about the shoulder and shoulder pain, and then we'll leave plenty of time for questions. So please think of those as we go along. This is pretty quick. It gives you just a quick visual representation of the places that I moved and went to in the military, at least that I was stationed at. I had multiple trips outside of this to other places in the world, a couple trips to the desert of Afghanistan as well, which we can talk about. And then ultimately, my final 7 years were in San Diego. So briefly, I grew up a military brat. My father was also in the Navy. He was a backseater in F-4 Phantoms. And we moved around multiple times, mostly on the East Coast. My last 5 years were in Anderson, South Carolina, kind of small town in South Carolina. I left there and went to college at the United States Naval Academy. When I graduated, I went Marine Corps option, met my amazing wife there, who's better than me in every way. And I don't say that just because she might be on this video. I say that because I know she's on this video and she told me I better say it. So, but it's true. And we got married. We went to the Naval Academy together, and then we were both Marine Corps officers for 6 years. So we did our training in Quantico in North Carolina, and then we're stationed in Camp Pendleton, California for a couple years. We lived in Okinawa, Japan for a year and a half, then back at the Pentagon Quantico for a couple years, and then she got out and I went to medical school for the Navy. The Navy picked me up to be a doctor. Went to medical school in Maryland, and then did my training in San Diego at the Naval Medical Center, San Diego, for 5 years as an orthopedic surgeon. In the Navy, they sent me out to be a general orthopedic surgeon, which I did 2 years up in Bremerton, Washington, at a naval hospital there. And then they sent me to get specialized training in shoulder and knee surgery for an orthopedic sports surgeon, which just means that you're specialized in arthroscopic and open surgery of the knee and shoulder, from minimally invasive reconstructive techniques all the way to replacement. I did that at Duke University for a year. And then they sent me back to San Diego, where I did my last 7 years in the military, and retired out after 25 years from San Diego, and had an amazing time, and was blessed to end up here with the Ryu Hurwitz Orthopedic Clinic. I've got some amazing partners. I've known Rick Ryu for many years. We've taught a lot of surgical courses together. And when he found out I was getting out of the military, he asked me to come up and join the group. This is Rick Ryu, Graham Hurwitz, Jervis Yao, and Danielle Thomas, my four other orthopedic partners here. They're all amazing, and I feel blessed to join them. As you can see, we take care of a lot of sports in town. It's just great to be part of the fabric of Santa Barbara. I'm really happy to kind of found a home and allow myself and my family to grow some roots here. Real briefly, I had so many amazing highlights in my military time, and it all had to do with other people. My amazing partners, my friends, my patients, amazing patients, active duty military, their families, retirees in the San Diego area. We took care of everything west of the Mississippi and everything kind of in the Pacific Rim area. My last multiple years, as discussed, I was one of the team doctors for the SEAL teams and Marine Corps Recruit Depot. So a lot of amazing people. Unfortunately, a lot of amazing injuries and accidents that we were able to take care of and try and keep people on duty. The military offered me a lot of precocious leadership opportunities at a young age. In the Marine Corps, I was leading Marines right out of college, and so that kind of prepared me for that. But in medicine, even in the first duty station, within a year of my first duty station at a hospital, I kind of took over as department head of orthopedics, small orthopedic department, kind of able to get your feet wet a little bit. Deployed to Afghanistan at that time as the sole orthopedic surgeon at the trauma hospital in Kandahar there. Went off to fellowship, came back to Balboa, was able to take on multiple leadership roles, as well as another deployment to Kandahar, where I was, again, an orthopedic surgeon there doing trauma, and then the hospital chief medical officer. Was able to come back and be chief of sports at Balboa, and then the associate director of surgical services. So kind of overseeing all the surgical fields at the Naval Hospital Medical Center in San Diego. So again, I put together kind of 10 things to know about shoulder pain. This is probably actually a much harder conversation and lecture to give than most that I give on multi-ligament knee reconstructions or glenoid bone loss and instability of the shoulder, because it's kind of very broad, and I'm not exactly sure what everybody wants to hear or what you're looking for. So just thought I'd hit some highlights of what comes into clinic, what you should know, what I can help you with. And then again, I'm going to leave plenty of time for questions so you can kind of ask those. So first of all, anatomy, right? As an orthopedic surgeon, probably should start there. I'm sure you probably know you're on this call, but in the very basics, we're doctors and surgeons of the musculoskeletal system. So not only bones, but ligaments, muscles, joints, cartilage, all the things that kind of allow you motion, allow your body to move in space. At the very basics is bones, and we're kind of known as bone doctors because we do fix fractures and replace joints, and it's a really fun part of our job. But when we're in training, we're taught that anatomy is surgical power. So knowing your anatomy allows you to perform safe surgery, to know when you're safe, know when you are not, what parts of the cases you can be very efficient in, and what parts of the cases you need to be very careful. We're talking about the shoulder. So this is the shoulder the big ball and socket joint, the glenohumeral joint. You have a small joint right above the acromioclavicular joint where your collarbone kind of meets your scapula or shoulder blade. And you can probably see there that the glenoid is a very shallow joint. So kind of like if you imagine playing golf with a golf ball and a tee, that ball would fall off that tee all the time if it's pushed. Same thing with the shoulder. If all we had was our osseous or bony anatomy, we would dislocate the shoulder all the time. So we were given a capsule and we were given muscles and ligaments that surround that ball and socket joint and keep it in a place. This is the next kind of slice of our anatomy after our capsule and our ligaments, which is our muscles and tendons that kind of grab onto that humeral head and keep it in place, especially when we're moving in space in different positions. So these are your rotator cuff muscles and tendon, and you probably hear a lot about rotator cuff problems, and we'll talk about that here soon because it's one of the most common reasons people come in to see me. But you have one in the front and then kind of three that go around the top and back of the shoulder. That subscap in the front, and supraspinatus, infraspinatus, teres minor. Super meaning above, spinatus meaning the spine of the scapula, so above the spine, below the spine. They help do different actions of the shoulder, and they can be overused, they can be partially torn, they can be tendinotic, and they can be fully torn. So outside of the anatomy, and then obviously over top of that, you have your deltoid and your skin, which also help with your function. So outside of the anatomy is really important to know. People are going to come in, they're going to say they have a problem. Oftentimes you'll come to see me, you've already got x-rays that allow us to look at the bones. A lot of times you have an MRI that allows me to see the soft tissue, such as the rotator cuff, the labrum, etc. But we don't treat x-rays, we don't treat MRIs. They help us, but we treat people. So that's why a good exam is key, and making sure that that you receive a good exam, right? So the shoulder can be, I kind of call it a black box, right? There are multiple sources, potential sources of pain in the shoulder. First of all, it might be coming from your neck. The last thing you would do is want to get a shoulder surgery and realize the pain is coming from your neck. So cervical pathology, that small joint, that AC joint, it could be your biceps if the pain is mostly in the front of your shoulder. It can be where that biceps, the long head of the biceps inserts on the top of your shoulder, your slap, so your superior labrum anterior posterior. If you're a sports fan, you often hear about slap tears in pitchers. It could be just some impingement where the humeral head is being impinged on the top of the shoulder. And I got a little video I'll show about that. It could be your rotator cuff where it's a partial tear, tendonitis, or a full thickness tear. Another thing we'll talk about is adhesive capsulitis, which is a strange bird and just kind of comes on. A lot of people wake up with it. And then it could be instability or your shoulder that kind of moves in and out of socket or partially moves in and out of socket, tearing that labrum. So I try and put things in boxes. I stay organized with my exam in boxes. So the things that can cause pain, I try and go down my exam in that same way and keep things together so as things don't get lost in the mix. The interesting thing, though, is that there are no exams that we know that are perfect. There's no perfect exam that I say, yep, this is exactly it. So we have to kind of use them all and kind of pull in all the information. And also, a very important part is what you say is bothering you, how it happened. Is it getting better? Where is the pain located? These are all really important for us kind of unraveling that mystery of shoulder pain. So first of all, we look, visual inspection. Want to look at your skin. Do you have any atrophy of your muscles? Do you have any arthritis of your joints? Then we go into range of motion. Now I'm going to be very quick about this. I know I'm not giving a talk to other orthopedic surgeons, although there may be some on the line. I would love it if there are. Thanks for coming. But there may be physical therapists online, and there may just be people that accountants and teachers and lawyers out there that are just interested about shoulder. So I'm going to try and keep this really broad, but then you need to go into range of motion. So checking, the shoulder throughout a range of motion. Where are you having pain? Are you getting stuck anywhere? Is it impinging anywhere? What's your strength like throughout this range of motion? And then I start getting into my boxes. The first being your AC joint or your acromioclavicular joint. And this is just a picture there. Someone testing some cross-body adduction. Is that small joint in the top of your shoulder? Is it grinding? Is it clicking? Is it causing pain? From there, you can move right down to the long head of the biceps. So bi means two, biceps are two heads of that muscle that allows us to do curls and more so supination, like turning a screwdriver, turning a wrench. The one goes up to your coracoid and one goes into your actual shoulder in your superior labrum. So do you have pain there? These various tests, Spies, Jorgensen's, uppercut, do those cause pain? Those all help us point to the biceps. And then the slap, which is an extension of that biceps. O'Brien's test, is it getting caught there? Is it causing pain? Impingement, this is just some pictures. So when you bring your shoulder up and cause that ball of your humerus to hit the underside of your acromion, is that causing pain? Is it swelling up the bursa that's underneath? And I'll show you a video of that. Or is it hurting that partial thickness rotator cuff? And then testing the actual individual muscles of your rotator cuff. So your supraspinatus in forward flexion and a little bit of abduction, your infraspinatus at the side, your teres minor with a horn blower, and then your subscap in the front with either resisted belly press or lift off test. These are all testing your individual muscles and allowing us to see, what is your main problem that you're coming in. Finally, instability. So rotator cuff tears or problems, typically we see those a little bit later in our life, unless it was like an acute injury, like a motorcycle crash or something. Instability is typically kind of younger. When we're very active in sports, we're throwing baseballs, we're catching footballs, things like that, shoulders popping in and out of socket. And we have various tests for this, including apprehension, Kim's test, jerk test, and then a load and shift test where we're actually shifting the shoulder, seeing how much it goes over the rim of the glenoid. It's very important that this gets tested and assessed and correlated with the other side, compared to the other side. Some people are born with more laxity than others, and that doesn't necessarily mean it's a problem. So here's a little video. It's a little bit long, but they say a picture is worth 1,000 words and a video is worth 1,000 pictures. So this is kind of the shoulder, and it shows you that bursa that's over top of your rotator cuff that can get swollen, inflamed, and impinged on the undersurface of your acromion, which is the bone that's above your rotator cuff, protecting that rotator cuff. You can also have inflammation of that tendon. How does it happen? It can happen through a variety of things. It can happen through overuse, injuries, like I said, usually in more kind of middle to older age, actually. People that do a lot of overhead activities, working on cars, engines, yard work, many different occupations that will cause this. That's just showing your inflamed bursa. And the bursa is a fluid-filled sac that kind of helps with the tendon and muscle to move smoothly. You can also get bone spurs up there that can kind of cause some fraying of the tendon. What are you coming in with? What kind of pain are you coming in? Usually shoulder pain down the side. Worse, a lot of times it's worse at night, like problems with sleeping at night, some stiffness, sometimes some weakness or difficulty raising your arm overhead, and radiating pain down the arm. Again, it's important for us to find out where in the shoulder are you having the pain. Is it in the front? Is it the top? Is it in the back? All this kind of changes what we're going to be looking for. So, we kind of talked about this, but how does this cause? How is it caused? Well, really, it's kind of bimodal, right? So people come in, I don't know how. It's just overuse. It's happened with time, repetitive activities. That's usually more of the chronic degenerative changes, inflammation, bursitis, versus I fell off my bike and now I can't raise my arm. That's usually more of an acute tear. So tendonitis, bursitis, that's kind of the lowest level of problems we get in the shoulder in this rotator cuff. And usually these do not need surgery. They're treated with a period of rest, activity modification, anti-inflammatories. Occasionally we'll do injections in the shoulder in the subacromial space for that. And then physical therapy can be worth its weight in gold for certain problems, especially this. So we'll often kind of do a combination of all of the above. However, when you start to have tears, we need to be a little more concerned. And a tear is not a tear is not a tear, right? There are a lot of different types of tears. Here's a normal tendon. So that black, dark, thick tendon that's coming in and attaching onto the humeral head there, that looks great. Then you can have kind of more full thickness tears with small amount of retraction, all the way to massively retracted rotator cuff tears in the shoulder. So we look at a lot of things. What's your chronologic age? Although that is just a number, especially here in Santa Barbara. I came from San Diego, tons of active people in kind of, their later years in life. So physiologic age is also very important. And I look at that when you come into clinic as well. How long have you had the tear? Can we tell how long you've had the tear? How big is the tear? Are you able to do the rehab? Is it the right time in your life to be able to do that? Another very important thing that we actually use MRI for is looking at your muscle. Is the muscle still healthy? If that tendon has been torn off the bone for a long amount of time, the muscle will continue to fire, but it's not doing any work. It's kind of like your engine running in your motor running in your car without turning any wheels. It's not doing any work. That muscle will actually turn into fat. And then it doesn't matter how many stitches I put in it, it's not going to have any function left. And then what other injuries in the shoulder that might, make us want to go to surgery or not go to surgery. For full thickness tears, for the reasons I discussed about the muscle turning to fat, and to preserve function and activity, arthroscopy or surgery is often recommended. And this just gives you some tools of the trade here that we have. We usually can use small arthroscopic portals, little portals for that scope, and all these arthroscopic instruments to go in, assess that tear, clean it up, clean up the bone, bring that tear over to where it needs to be, and put it down with anchors and sutures. It's amazing the partnership that we've had with industry as orthopedic surgeons to be able to increase what we can do arthroscopically and from what we used to have to do open. Just a picture of kind of before and after a big tear. You can see right through the top of the shoulder into the shoulder joint, and after a repair here, you can no longer see that. All right, 7, long head of the biceps problem. So as I talked to you about, the biceps has 2 heads. The one that's more commonly involved is the long head. And it goes right up the front of the shoulder, especially when your arm is externally rotated a little bit. And you complain of shoulder pain right in the front of the shoulder, especially when like turning doorknobs, turning wrenches. You can have tendonitis or inflammation of the tendon. You can have partial thickness tears. It can be torn off from that superior labrum up top. And what to do about it? Well, a lot of times we just send you to physical therapy, anti-inflammatories. We can do ultrasound guided injections in the sheath or in the glenohumeral joint. And then sometimes, especially when there's instability of the biceps, we recommend surgery. Surgery for that, if it's torn at the superior labrum and you're a young active duty or active person, still doing a lot of overhead activities, occasionally we will fix that labrum up top, or we will cut the biceps where it inserts up top, as you can see on that third picture, and then reattach it in the groove to the bone through a variety of different methods. This still keeps the same length tension relationship of the biceps and allows you to kind of do everything you still want to do with that arm. Frozen shoulder. I want to just keep this picture up here so you can see a little bit of this. This is a good kind of picture showing that there's like adhesions to the undersurface of the acromion, really thickened capsule around the glenohumeral joint, adhesions to the coracoid in different areas. And it's a really interesting problem. It's not interesting if you've had it, you probably hate it, or if you have it right now. but it will affect, 5 to 10% of the population. They'll have this adhesive capsulitis, which we commonly call frozen shoulder. And a lot of times you just wake up. You wake up, you have pain, and you can't move the shoulder as much. There was no injury. And we look at kind of your history, your increased risk if you're over 40, diabetes, thyroid problems, other medical conditions, more commonly in women a lot of times. And then we do a good exam and try and help parse this out from other problems. There's kind of three phases of frozen shoulder. That painful phase, which comes on immediately. You start to get frozen and more stiff, and then you thaw out. So kind of this bimodal distribution here with range of motion and pain, kind of getting worse and then getting better with time. But this can last up to a year and a half without any kind of treatment. So what do we do? What do we do to kind of help move it along? We can do light stretching, other modalities, anti-inflammatories, heat or ice, and then often we'll recommend a steroid injection in the ball and socket joint to kind of help break up those adhesions, cool down that capsulitis. For some rare cases that just won't get better, we can do a manipulation or actually go in with an arthroscopy and release the capsule so to get some motion again. The AC joint, that small joint on the top of the shoulder. This can get arthritic. It also can have arthrosis, we talk about, which is not necessarily a bone-on-bone problem, but the small little disc that's in between gets diseased, inflamed, and sclerotic. And it causes pain on the top of the shoulder. Really, a lot of people can feel that joint on the top of the shoulder. They can feel the little ridge on top of it as it gets arthritis or as it gets arthritic. You have pain when you cross your body. You get crepitus or clicking when you cross your body, and it's often localized right at the top. I worked with a Southern surgeon at Duke, and he used to say, a dog can have ticks and they can have fleas. They can have both problems, and you can too, right? So you might have this and you might have other problems. You might have a degenerative rotator cuff tear. You might have arthritis of the ball and socket joint. So all that's important for us to look at. This can often be treated just with finding out what kind of activities cause it pain. For people that are still very active, that's usually overhead activities, dips, things across your body. And if you can get away without doing some of those, you can live with this the rest of your life. But some people with their jobs or activities, it just continues to flare up. We can recommend an anti-inflammatory gel like Voltaren, or we can do a steroid injection in the ball and socket joint to kind of help both therapeutically and diagnostically. And then ultimately, if you're not getting better, we sometimes go in and just resect that joint. It's called a Mumford. This picture on the right, it's a little bit aggressive resection. We wouldn't regress that much, but it's a little cartoon of it. This can be done arthroscopically or open, depending on the problem and the surgeon. And that usually is a definitive treatment for it. You can also have separations of the AC joint. A lot of that happens. You're riding your bicycle, you fall right to the shoulder. You're doing jujitsu or martial arts, you fall, you get flipped right to the shoulder. And it's elevated. And that's a whole nother topic that we can talk about if anybody has questions. All right, ball and socket arthritis, shoulder arthritis. This is that big joint. Right here, you have two pictures, one of bone-on-bone arthritis with that bone spur. We call that a goat's beard. That's the first thing we start seeing when you get arthritis in the shoulder. The one off to the right is called rotator cuff arthropathy. That's where you've lost your rotator cuff. You haven't had a rotator cuff for years. It's turned into fat. Now the ball starts creeping up and it starts articulating on the undersurface of your acromion. So you don't have the same wear pattern. You don't have the same arthritis, but it's still the same problem where you have stiffness, pain, can't move the shoulder. So what do we do about it? Well, again, we can treat this non-operatively. It's not cancer. It's not going to kill you. We don't walk on our hands, so a lot of people can tolerate shoulder arthritis. We can start with anti-inflammatories, some light stretching, physical therapy, injections, biologics such as PRP, BMAC, things like that can help in early arthritis. Arthroscopy with little poke holes if there's other pain generators in the shoulder and you're not really ready for a shoulder replacement. And then ultimately, the gold standard, the ultimate treatment for this is replacing the shoulder. Here's a picture of a regular standard shoulder replacement with a bone sparing type procedure. And then that's similar to the one on the left that has a stem in it. And then the one on the right is a reverse. So the ball becomes the socket becomes the ball. What do we do a reverse for? Well, that's for those patients with rotator cuff arthropathy that no longer have a rotator cuff to help them move the shoulder. So we have this different technique which medializes the center of rotation and allows your deltoid to have a lot better mechanical advantage to move that shoulder around. We also do a reverse for bad fractures of the proximal humerus that can't be fixed. So third, top, now we're up to number 3. And we've been talking about this all along these top 10s, but non-surgical management is very common. When you come to see me and other orthopedic surgeons, there should be at least a conversation of non-operative management. What are your options? You need to be an informed patient. You need to know the problem. You need to know your options. It's a shared decision-making process between you and the surgeon. And many of these orthopedic problems can be treated, at least initially, non-surgically, and kind of marched up the ladder of treatment options. Just as there are potential complications with surgery, it is important to note that there are potential complications and downsides with not treating certain things with surgery. And that's something that will be discussed between you and your surgeon. Number 2, what's new? This, I think, would be better to just share with questions. I want to leave plenty of time for questions, but there's, constantly we're looking at the new frontier of orthopedic surgery. How can we do things better without surgery? And when we do surgery, how can we do them better? So biologics is all the new hotness. And we've been looking at it for many years, trying to find the panacea of what can fix things, what can regrow cartilage, what can give you an 18-year-old shoulder and knee again. I will tell you, we have not found it. We are making progress with things like biologic injections, such as PRP or platelet-rich plasma, where we draw your blood, we spin it, we re-inject it, bone marrow aspirate, fat injections, things like that can, we're getting more and more data that those can be beneficial in certain types of problems, but we have not seen anything that's available that will, be that fountain of youth. And so there are, potentially places that will promise you a lot of things. And as an orthopedic surgeon, our reputation is very important to us. We never want to seem like we're selling snake oil. So it's important that you have that conversation with whoever you're seeing to make sure that you know what these injections can and can't do. Custom technology, when it comes to surgery, we're trying to get more and more patient-specific when it comes to our treatments for you. You demand it, we want it. I will tell you, looking at the literature, it doesn't always show that it matters, but we continue to try and be better and better with our technology in our field, kind of always trying to better ourselves. And then another thing along that line, when we're talking about the shoulder today, and rotator cuff's a big percentage of this talk because that's a very common reason people to come in, continuing to look at augmenting that rotator cuff repair. How can we augment it? Even if we do a perfect repair, you do perfect rehab, there's still a percentage of the population that just won't heal their rotator cuff. It may have to do with age, healing capability, other comorbidities such as smoking, etc. So we're always looking at ways to augment that repair and give it a better chance of healing. And finally, when should you see a doctor? That's obviously your call. But some things I'd recommend, you're not sleeping. Sleep is infinitely important to every part of our, being, our mind, our health. And so when your pain is keeping you up at night, keeping you from sleeping, it's probably time to get it looked at, do something about it. Activities, right? Motion is lotion. Um, you know, Being active is going to keep your heart healthy, is going to prolong your life, it's going to keep you happy, it's going to keep you right in the mind, keep you right in the head. So when you're not able to do the things you enjoy, when you look back and you say, here's my new normal, and it used to be way up here, and I'm just not happy with that you come in and see us. And then it's also important to listen to the ones you love, the ones that you trust, right? If they're telling you, hey, something's wrong, something's not right, you're not the way you used to be, it's time to get help. Here's some resources. I'll leave this up for a minute. When we talk about all these problems and treatment options, especially when we're getting in the fringe of treatment options like injections, the stem cell injections that people are selling, it's important to look at the literature. Sometimes the literature can be hard to understand. We kind of say in orthopedics, you can always probably find a study to support what you want to do. But those studies should be high quality studies, large number of patients, well-designed studies to really base our decision making off of. Again, I want to thank all of you for coming. I hope this has been informative, and I hope that I'm able to give you some time here, give the time back to you to be able to ask us questions or ask me questions about anything you want, my career, your shoulder, the rock, my partners, anything you have. This is my website. It's got a lot of patient information on it. Welcome to peruse it. Look forward to seeing you in the community.
Thank you, Dr. Bailey. That was a really informative presentation, filled with such good information. So now we'll move on to the question and answer session. We have quite a few questions, so we'll do our best to get through as many as possible. Just a reminder to everyone, please put your questions in the Q&A box at the bottom of your screen, and I'll read them off to Dr. Bailey. So let's start off with our first question. Wondering if someone is experiencing shoulder issues, could it possibly be a problem if they go for a deep tissue massage? Could that exacerbate the problem?
Yeah, it's a great question. I'm a big fan of physical therapy and modalities like physical therapy, massage, appropriate manipulation, chiropractic type treatment. There are a lot of providers out in our town in Santa Barbara that I've met that are excellent at treating a lot of these early shoulder pain problems. I would say, probably 90% of shoulder pain never sees an orthopedic surgeon. And usually that's very, very appropriate because it's very normal as we are active and as we get further away from 18 years old to have episodes of shoulder pain, whether that's from just overuse activities or small little injuries. And a lot of those will get better with time and activity modification, massage, physical therapy. Could it hurt? Sure. I mean, theoretically, I guess, if your problem is that, you have a dislocated shoulder, you're not going to want to go see a massage therapist for that. You're going to want to go to the ER and get a reduction, but those are very obvious type problems that you're going to have. So I think you're pretty safe. The big thing is if you have muscle aches, if you have a tendinopathy, doing a deep tissue massage may flare it up a little bit. May flare it up, so your pain may get a little bit better or a little bit worse before it gets better. But I think it's pretty safe.
Great. Are there specific exercises or stretches that could help keep a shoulder healthy?
Yeah, absolutely. So, um, you know, when I was in the military, you know, me and about everybody in uniform wanted to see, how big we can make our biceps and our shoulders and our traps and stuff like that. And I'll tell you that is great, if you're into it, but long-term, prolonged health of the body, we want to have healthy muscles, healthy tissues. I want to eat well. We want to preserve our range of motion the best as possible. Um, and to do that, it involves kind of staying active. So kind of more repetitions, less weight, keeping healthy, keeping strong. So, um, you know, there are, there are amazing physical therapists in town, and you can always utilize them. But also, there's great assets online. If you just look up rotator cuff physical therapy, Google rotator cuff physical therapy, find a physical therapist out there that's got some videos. He or she will show you some good motion exercises, such as, forward elevation, keeping your external rotation the best you can, and then using light weights or bands to kind of keep your rotator cuff strong. And how do you keep your rotator cuff strong? Well, it's essentially the same motions that I showed in the presentation of how you test a rotator cuff. So I'll try and back up here, but doing some bands or light weights or cables out here, doing some external rotation, some internal rotation, bending over and doing some external rotation. So a lot of rows, a lot of deep rows. One of the things we're seeing a lot of is tight shoulders in the front. Why? It's because we now live like this, hunched over on our computer, on our cell phones, on our tablets. We get tight pec minors. Our shoulders get internally rotated. Our scapulae get kind of pulled back like this. And we need to bring those scapula back. We need to do low rows. You need to pinch your scapula. You need to try and keep your posture as good as possible. I probably did half of my talk like this, so I am not a good person to model after, but trying to keep your shoulders back. The scapula is the foundation of your shoulder. When your scapula is off, everything's off. So working on that scapula is another good exercise to do.
Great, thank you. That's so helpful. It fixed my posture right now. Just kidding. Do steroid injections within the shoulder degrade or hurt the shoulder tissue? And if not, are there other adverse side effects besides limited relief?
Yeah. So it's a great question. And the literature is a little bit mixed about it. I mean, in general, as an orthopedic surgeon, we tell you, steroid injections are a very potent anti-inflammatory. That's what they are, right? And that's about all they do. It's an anti-inflammation medicine. So when you're flared up, when you have acute injury, when you have bad tendonitis, it can be very powerful. It can help with the inflammation. It can help with the pain. It can allow you to do better with physical therapy, but there can be a cost, right? If you look at the data, likely long-term multiple steroid injections can kind of cause some tendon weakening. It can cause tendon ruptures if it goes inside the tendon and not in the fluid space. It can cause cartilage degradation. So when we do steroid injections, it's usually for a very specific problem, and it's not considered a long-term treatment option. Now, I promise there are probably people out there who have been getting steroid injections of their knees and shoulders for years and years and years. And I will say there's a caveat to that, right? If you have bad arthritis and you don't want to replace your knee or your shoulder or your hip yet, then it's a reasonable option, because yes, it may speed up that degenerative process, but the surgery is still the same. We're still going to replace that joint. In the shoulder specifically, there's been some studies saying that steroid injection in the ball and socket joint, not up in the subacromial space, but in the ball and socket joint, may potentially increase your risk of an infection when you do get a shoulder replaced. Very, very small, but may. So some shoulder surgeons are kind of backing away from doing shoulder steroid injections unless it's for something very specific like frozen shoulder. And I'll tell you, that's where the biologics has become really big, right? Because steroid is not perfect. And although it is a great, powerful drug, you know, biologics like PRP, BMAC, uses your own tissue to kind of create a better environment in that space. It's full of growth factor proteins that help your body kind of heal, recover, and speed up that kind of its own ability and process to heal with very, very little downsides, except it's not covered by insurance. And that is a downside. That's a very real downside, especially in Santa Barbara. I get it. It's expensive. So that's something that anytime we're charging something for someone for a procedure, we need to be really upfront with, what can that do and have appropriate expectations.
Thank you. Our next question, do rotator cuff tears inevitably require surgery, or is it possible for them to heal on their own?
Yeah, it all depends on what type of rotator cuff tear. This is a spectrum, right? So you can have tendinopathy, inflammation of the tendon. Yes, those have the ability to heal. You can have partial thickness tears where, if you imagine, a tendon on a bone where the undersurface is torn some, but the top isn't, or the top is torn some, but the undersurface isn't. Those sometimes will heal. But even if they don't heal, those often we will watch. They don't always progress to full thickness tears. There are studies also looking at some of these biologics and partial thickness rotator cuff tears that can help speed up the recovery of these as well and be as efficient as taking it down and doing a repair. Now, I will tell you, when you have a full thickness rotator cuff tear where the tendon is no longer attached to bone, these won't heal. These won't heal. If you're young and active, that is when we have that discussion with you about non-operative management, but we recommend surgical management to get that bone down to tendon, because the longer that bone's not attached to, or the longer that tendon's not attached to bone, the more retracted, scarred down it'll get. And then over time, that muscle can turn into fat, and then it's useless. And you can't fix it anyways. And then you look down the road that your only real good option is that reverse shoulder replacement.
Oh, wow. So interesting. Will an X-ray show enough for a diagnosis, or would an MRI be a better option?
Yeah. We get asked this a lot. So X-rays show bone, and essentially bone only. Sometimes on an X-ray, especially a knee, you can see some shadowing over the bone, which show that there's an effusion or a swelling in the knee, and that can give us a hint that something's wrong inside the knee, like a meniscus tear or an ACL tear, but it won't tell us what, right? It won't tell us what. It only shows bone, so it doesn't show cartilage, it doesn't show tendons, it doesn't show ligaments. That's what an MRI is for. So if someone's like, in their 70s or 80s, they have pain in their shoulder, they have grinding in their shoulder, and they can't lift it as high as they used to. An X-ray often will give us what we need because it'll likely show that they have arthritis, and that will show us enough. But a lot of problems, we do rely on an MRI and a good physical exam to kind of come down to the ultimate diagnosis.
Okay, thank you. So how common is calcific tendonitis, and what is the treatment for it?
Yeah. Calcific tendonitis can be very difficult, not only for patients, but also for surgeons and other providers. Calcific tendonitis, for obviously someone out there has it, and sorry for you. I know it can be very painful, but it's calcium deposits within the tendon. To be honest, we don't really know why it happens. You can go to AAOS, calcific tendonitis. There's a great, patient-centered website about it that gives you information on what it is, why people get it, which we don't know, and treatment options for it. A lot of times, calcific tendonitis will kind of burn out on its own and get better on its own. At times, whether it's because it's just the pain's too much, the function's too limited, they have a job that they have to be able to use their shoulder, and the calcific tendonitis is not allowing them to. We can do a steroid injection. We can do a procedure where essentially it gets blasted with fluid to break it up. And then we can do arthroscopic surgery to kind of remove those calcific bodies in the shoulder. But occasionally that'll leave holes, that'll leave full thickness tears that require a rotator cuff repair.
Okay, thank you. So, does bicep tendonitis ever call for surgical intervention or mostly stretching therapies?
Yeah. So biceps tendonitis in conjunction with other problems in the shoulder, we will often treat surgically because we're there doing it. I will tell you, isolated biceps tendonitis usually can be treated with physical therapy, stretching, anti-inflammatories, activity modification. Like we had talked about before, sometimes we'll do like an injection in the bicipital groove to help calm it down. But really, you want to look to other sources of pain, and is that really isolated? It's hard to find that as an isolated problem. It can happen, but usually there's something else going on. And you also want to look at where that biceps is inserted in the top of the shoulder, in the slap region. Is there a tear up there or not? But usually those can be treated without surgery. But if not, we have treatment options for them.
Okay. What about individuals who have difficulty tolerating NSAIDs? What alternatives are there for tendonitis?
Yeah. A lot of people can't take NSAIDs, right? They can't take, and an NSAID, there are so many out there, right? There's ibuprofen, there's Advil, there's Motrin, there's Mobic, there's naproxen. It comes by a variety of different names, Celebrex. So these are all NSAIDs, and they all can have some side effects, mostly GI side effects. So people that have GI bleeds or have had complications with anti-inflammatories in the past. They're also excreted through the kidneys. So people with kidney disease is not always great. So there are people that can't take NSAIDs. I will tell you acetaminophen or brand name Tylenol, but you can just get acetaminophen anywhere. That is also a very good drug, over-the-counter drug. And even though it's not really called an anti-inflammatory, it does a good job at that as well. That's excreted through the liver, so it's a little bit different mechanism, and you can use that. I will tell you, if you are using NSAIDs or anti-inflammatories, you want to make sure you take those while you eat. Because it can kind of give you stomach problems and stomach distress. So Tylenol is an easy one. People who just have GI problems with NSAIDs can also try like a topical NSAID, like Voltaren gel. And that's over the counter now. It used to be prescription, is over the counter. So for aches and pains that are very close to the skin, that can work. And then we come down to a little more invasive type treatment. For aches and pains of joints, there are a lot of nutraceuticals out there. So like chondroitin, those kind of joint jelly or joint pills that you can get at CVS or Costco or Amazon. The science behind those is a little bit iffy, but I have plenty of patients that swear by them. So I usually recommend, if you're going to take one of those nutraceuticals, take it for a month and then come off of it and see if it was helping or not.
Thank you. What part does the neck play in shoulder pain?
Usually neck pain and shoulder pain is pretty distinct and separate. But not always. Obviously, the neck has multiple nerves that are coming out of it that kind of go down the arm. So if you are having pain that radiates from the neck down to the shoulder, that's typically when it teases us off a little bit more to look for that cervical pathology or cervical pain. Doing a range of motion of the neck, doing what's called a Sperling's exam, where we're pinching the nerve on one side or the other. If that reproduces your shoulder pain, it's probably not from the shoulder. And then we send you to one of our spine surgeons, like a spine surgeon buddy of mine who's texting me, making fun of me right now. I'd send you to him.
Thank you. Next question. A few folks have asked, do you only specialize in shoulders, or are there other other joints that
Yeah.
you specialize?
So I'm a sports surgeon, orthopedic sports surgeon, and that's a bit of a misnomer. This doesn't mean I just take care of athletes or take care of a sports team. I do that, but it's mostly the field of pathology that I take care of. So not only sports-related injuries, but overuse injuries, joint injuries. I am a shoulder and knee specialist, cradle to grave, everything from arthroscopic, reconstructive, cartilage reconstruction, meniscus, ACL, ligaments, labrums, rotator cuff, and then knee replacements and shoulder replacements. That being said, as a team physician, as a shoulder surgeon, as prior military doctor, I see aches and pains of all parts of the body. And so in my clinic, I often will see people for back pain or hip pain or other parts of pain. And if we can manage most of that without surgery. And if it comes down to a surgical management and something that I don't do, we get our patient to someone who does.
Okay, perfect. Well, time has gone by very fast. We have time for one more question. This last question is, what is follow-up like after surgery? So you've had surgery. What is follow-up like with you, and does it entail physical therapy?
Yeah, that's a great question. I would say, it's surgeon specific. Everybody's a little bit different, and it also kind of depends a little bit on what surgery was performed. But ultimately, after surgery, you are going to have follow-ups with your surgeon or whoever they deem is going to be following you up. Here at the Ryu Hurwitz Orthopedic Clinic, it's a surgeon-only clinic. So you'll see me back every single time, usually somewhere around 10 to 14 days for your first post-op to take a look at your incision, make sure everything looks good, get you on the right track with physical therapy, and then see you back usually at the 6-week mark, 3-month mark, and 5 to 6-month mark. But again, it all depends. Everybody's a little bit different, but yes, you will have scheduled follow-up with me to make sure you're doing well. And then you will have, almost always will get you into an organized postoperative physical therapy. I tell people that my part's really the easy part, right? I have a small part in the overall recovery of your injury. I do the surgery. And then the hard work starts, right? Then you're putting in the hours. You're putting in the hours with the physical therapist. They're worth their weight in gold, and you're making the gains day by day, week by week, month by month, to kind of get better. If you have surgery by me and you don't do anything after that, you don't move your joint, you don't do physical therapy or at least your own home physical therapy, you could potentially be worse than when I saw you when I started. So. It's a team approach. I am one member of the team.
Perfect. Well, thank you, Dr. Bailey, and thank you everyone for your questions. Thank you for joining us this evening. Dr. Bailey serves at 2 different locations at the Ryu Hurwitz Orthopedic Clinic. The main office is in Santa Barbara at 2936 Della Vina Street, and he sees clinics on the last Friday of every month in Santa Maria at Sims Physical Therapy and Sports at 2530 Professional Parkway. For more information, please call 805-963-2729 for either location. Again, this presentation is being recorded and you will receive an email within the next week with a link to view the presentation and PowerPoint slides. A brief survey will appear after this webinar closes, and we'd love to hear your thoughts. So thank you again for joining, and have a happy and healthy rest of your evening.
Yeah, thank you, everybody. I really appreciate it, and look forward to seeing you around town and becoming part of the fabric of Santa Barbara. Thanks for having me.